So, hello everyone. My name's Marie Gabriel. I'm the chair of the NHS Race and Health Observatory, and I'd like to say welcome to the webinar launch of the report Trauma-Informed Care and Racialised Communities. The webinar is hosted by the Centre for Mental Health in partnership with the NHS Race and Health Observatory. I will be co-chairing the launch event today with the wonderful Professor J.S. Bamrah, and during this hour you will actually hear 3 presentations regarding the report findings and practice, and then the speakers will form a panel chaired by JS who will put your questions. We want to try and make this as interactive as possible, including the ones that were sent in advance of today. I just want to start off by saying that we are actually mindful that this topic can be that we are actually discussing can be very distressing, and we have put a link to resources within the chat, and if people feel the need to sort of drop off and you can come back in, then that's fine, and we'll keep an eye on people who are seeking to return to the launch event. And so I just want to start with the pleasure of introducing our presenters. Our first presenter will be Dr. David Woodhead, who's the Associate Director of Research at the Centre for Mental Health, and David's going to provide an overview of the project and its findings. We will then move on to a joint presentation from Afrik CIC, and that will be Abdi, who is the founder of Afrik, and Khaleel, who leads on their youth work. And they actually will be they're a research partner as an organisation, and they're going to build on David's presentation, but grounding that presentation in frontline practice and lived experience of work with young people and communities. So without further ado, I'm going to ask David to present the findings. Just to say again that the full presentation will be available post the seminar. Over to you, David.
Thank you, Marie, and good morning, everybody. Can I just check, someone put their thumb up that you can hear me okay? So, yes, thank you. Oh, so I'm David Woodhead. I work at Centre for Mental Health. We were delighted to work on this research with our colleagues, our dear colleagues at Afrik, and with the very generous and supportive commission from the NHS Race and Health Observatory. You will see that there are names there, Abdirahim, Doreen, Aditola, myself and Andy, who all worked on the report. So whilst I'm doing the presentation today, this really wasn't my labour in any great sense. It was the people, these authors that you will see both here and on the report, and indeed, hopefully will be part of the conversation. Have the next slide, please. So the context, sorry, next slide. So the context in which this research took place was that there is a very strong evidence base, lots of commentary, as I'm sure you're aware, both academic and political, activist and policy related, that sets out the domain in which we wanted to understand more clearly what would work in order to address racialized trauma. So first of all, there was the acknowledgement of the high levels of trauma amongst racialised communities, and the antecedents and the causes of those relate to racism and discrimination, structural injustice. That trauma is not a one-off or singular or individual event. It is cumulative, it is intergenerational, it is experienced in the here and now, but it is shaped by a history of slavery and colonialism and displacement, and also is reinforced very much by contemporary experiences of healthcare, policing and housing and employment. And that we know that there are some big issues that fortunately have been discussed in some depth recently, the Windrush scandal, the overdiagnosis of psychosis, discriminatory school experiences, all illustrate our institutions which should be looking after us and protecting us and enhancing our experience of life actually can cause and reproduce trauma. The next slide, please. So where are the gaps? We know that trauma-informed care is a thing. It is an approach. It's had lots of discussion. It's gaining credibility. Most places are talking about it and are trying to implement it. But what we found in the literature and also in our discussions is that actually the approach to its implementation is pretty fragmented and inconsistent, and that rarely at the heart of it is an understanding of racial trauma and what needs to be in place. And what that does, of course, is that not only leaves things being unaddressed, but also can create mistrust when people are trying to access services in some desperation, when they're actually facing language barriers and stigma and indeed negative experiences. And that there are studies, but nothing really. There's lots of studies into trauma and the nature of trauma and its antecedents and causes, but understanding what we can do about it for racialised communities, the evidence base is thinner. Next slide, please. Next slide, please. So these were the questions. What is the nature of trauma experienced by people from racialised communities? The second question, the key question, was how can services be improved to better support individuals? And thirdly, what strategies can service providers take to be able to make sure that the services that they're delivering actually are fit for purpose for the diverse and many needs of people in their breadth from racialised communities? Next slide, please. So the research methods, there was a four-pronged approach. We did the literature review, the kind of insights from which I've just shared with you very rapidly. There was a community reference group. This was a very innovative approach, and we were delighted to work with Afrik on this, which was a group of advisors made up of young people from racialised communities who, it's a group convened by Afrik with people with whom they have engagement. There was an online survey with professionals and across mental health and education and other services, both in the public and voluntary sectors. And finally, there were a number of focus groups and interviews where we spoke to service users and people from those communities in their breadth, from African, Caribbean, Asian, Middle Eastern, and refugees and asylum seekers, to try and understand the nature of their trauma and what they have experienced and what they think will help. Next slide, please. Sorry, I'm drying up here. Okay, I'm going to take you through the headlines of what we found. I think this will be familiar to you, so I'm not going to go into a lot of detail, and we want to save as much time as we can for the conversation. But our first headline was that trauma is widespread and rooted in racism. And whilst those two things are understood by communities that are affected by them, they're not necessarily very widely understood or well understood outside of those communities. And the issues around trauma and how they link to the histories of racialized communities is really key and needs to be better understood. Next slide, please. Our second headline was very much that public services actually can reproduce trauma, not routinely, but very, very often. And by public services, we were not just talking about health services, although that was a central concern for the report, as you'd expect. But we're also thinking about policing and housing and social care. And we heard stories about where people were dismissed because their symptoms did not fit what clinicians thought were the symptoms for particular conditions, because they were trained in very Eurocentric models, or that there was definitely a gender axis here that needed to be explored because women were blamed often or disbelieved. And that also we know that the negative interactions of police and their behaviours in some communities. And what this did is it not only reproduced trauma, but it left a deep legacy of mistrust. Next slide, please. So the third headline is that trauma-informed care does happen. It is a thing. It is being taken up. People are talking about it, but it's inconsistently applied, and it seldom really is sufficient in its conceptualization or its definition, and certainly not in its operationalization, in its delivery. It's not sensitive enough to the needs of people from racialized communities and the very specific impacts of race-related trauma. Next slide, please. And our final headline, really, I mean, there's lots more in the report, and I would encourage you to read it. But our final headline was very much about if within communities, within racialized communities, there are leaders and there are services, and there is knowledge and understanding and a deep commitment that actually is not at the moment properly engaged, and it needs to be engaged in a sustained way, and that in order to do that in a sustained way, it needs to be funded properly. And when we mean funded properly, we don't mean one-off bits of funding, but thinking long-term about how we actually prioritise these activities and work with these communities who have great needs, but also huge assets and huge insight and many ideas about how to do things better. Next slide, please. Okay, so moving into the conclusions. Next slide, please. So our first conclusion is that, as we've said, and it is a theme that is said throughout the report, and we will keep repeating it, is that trauma in racialized communities is an historical phenomenon. It is about what's happened to communities. It may not be, even for people that, even for young people now, for whom those direct experiences of colonialism away in the past, there is something traumatic held in those communities and needs to be accepted and understood. And that actually a generic, but also, and I think I would, this is something I have to keep my own mind on, given where I sit in this picture, is that talking of racialized communities in a very kind of singular way is also a big problem, because it really is, whilst there are some principles that are universally applied, we do have to think that this is not about having one size that fits all. The diversity of communities and the diversity of people means that trauma may manifest itself in very different ways, but that doesn't mean that we shouldn't be ignoring it. Second conclusion, please. This, I think, is something that is really important for us to think about, is that very often with mental health care and with trauma, we think about individuals, and of course we do. It's absolutely critical that we respond to individual needs, but we have to think about trauma as being a social and cultural phenomenon also, and that it's a consequence of systemic injustice. It's not about individual events necessarily, although individual events can be devastating. It's about accumulation of prejudice and discrimination and violence, epistemic and material violence, over many generations. Conclusion number 3, please. So this is this point about the leadership and the strength and the agency. I've written agency twice on that slide. That's just to impress just how much agency there is. Leadership, strength and agency within those communities, and that actually the way through this, the way to support this, is not only to put an end to the trauma, to make huge steps there, but also to for those services that seek to support people who are living with it, that actually genuine partnership with communities is absolutely essential. Next slide, please. Here we go. So now we're getting into the recommendations. So we've written 8 recommendations. There are 4 on each of these slides. I'm not going to go through every one in every great detail, but just to say that with the NHS ones in particular, what we're saying is you have opportunities with the patient and carer race equality framework, and also with the CQC standards, and also there are other levers. There are opportunities to really think systematically when you're building capacity in the NHS at all levels, as commissioners and also as service providers, to become more trauma informed. Then don't make any progress on that particular canvas until you're really embedding and understanding how this affects racialized communities, and how that might be or might not be different to other people. So there's a definite role there for NHS England and DHSC and integrated care boards and other NHS bodies. The government also has an opportunity in its publication of the Race Equality Act, that seems like a very ripe opportunity to make these arguments very clearly. So funders obviously we have to address this deep problem about funding for community-led organisations, and the precarity with which organisations that everybody acknowledges are absolutely crucial actually are not. There's no underpinning or little underpinning for them to be able to consider how they might continue or indeed develop and enhance their work. And finally, there's something about training, when we're training clinicians, training social workers, training teachers, that trauma-informed and anti-racist practice is at the heart of that, with a specific recommendation you'll see at the end for the Department of for Education in relation to thinking about curricula and about really understanding and sharing what racism is, the history of racism and colonialism, and also to be able to work in a way that identifies and addresses so-called racial microaggressions, which in my opinion are very much about the aggressions and not always so micro. Next slide, please. I just want to, and I hope this isn't a shock to anybody, but I just want to end this presentation because Doreen Joseph, who was one of the key members of our research team on this, and indeed has worked with us, with the centre in many ways over many years. We are very saddened to hear that she has died. She left a very strong legacy. It was and I just wanted to acknowledge, not only because of the work she's on this project, but because of the contribution that she made to the field. And I just hope in a small way this very rushed presentation stands as a tribute to Doreen's contribution to the field and the affection with which we hold her and will continue to hold her. Thank you, Marie. That was very quick.
Thank you, David. And I can see some hands are up. We're going to take all the questions after the presentations. I hope that's okay. And that was a quick but actually very insightful summary, David. I'm now with pleasure handing over to Hassan, the founder, and Khaleel Mohammed, youth lead at Coffee Afrik at CIC. Over to you.
Thank you very much, Marie. I really appreciate it, and also just want to extend my condolences to David and of course to the team at the Centre for Mental Health. Doreen was an exceptional person, and we enjoyed really working with her. Also want to thank Sam and the Race and Health Observatory for the support during this project too. My name is Abdirahim Hassan. I'm the founder of Coffee Afrik CIC. We are a Somali-led organisation rooted in East London, Tower Hamlets and Hackney predominantly, working across racial justice, youth leadership, mental health, and community well-being. Our work is grounded in care, dignity, and liberation. And particularly, I think about the liberation of all of our marginalized communities. We build spaces for young people, families, and communities to heal, to organize, and to lead. And we are one of perhaps the early organizations, certainly in Tower Hamlets, that I can think of, that are Black-led and Black-rooted and community-rooted, working at the intersection of public health and specifically systems change. We're very inspired by this idea of influencing leaders. But more than anything, Coffee Afrik is a response to what happens when systems do not hold our people with care. I think someone who talks about somatic practice a lot in trauma, I really want to begin from the body and from what we carry. Before we talk about systems or services, we have to name something deeper. Many of our people are tired, especially right now. Not just tired, but tired in the body. We know that when stress is constant, when you are navigating racism, exclusion, instability over years, even generations, it does something to you. It lives in your nervous system. It certainly lives in mine. It shapes how you breathe, how you sleep, and how you move through the world. For many Black and racialized folk, that feeling of being on edge, always alert, always bracing, it is real, it's not imagined. So when we speak about anxiety, depression, trauma, we are not speaking about isolated experiences. We are speaking about what it means to live in a world that does not always feel safe for us. And yet the knowledge we use to understand that is limited. Our ancestral ways of healing, our community knowledge, are often pushed aside while dominant systems position themselves as early authority. So part of this work is also about reclaiming that ancestral knowledge for us. So the research, and to specifically focus on that too, the co-produced research with the Centre for Mental Health, which is trauma-informed care racialized communities, begins from living experience. I prefer to use that phrase more and more instead of lived, as I certainly am living still the experiences day to day. It shows clearly that trauma in racialized communities is not individual. It is structural, it's layered, and it's intergenerational. People, particularly young people, spoke about racism across every system: education, migration, housing, policing, healthcare, not as isolated incidents, but as daily realities. They spoke about being dismissed, misdiagnosed, criminalized, about systems that do not just fail them, but re-traumatize them. And this is, of course, backed by national data. We know that Black people are 3.5 times more likely to be detained under the Mental Health Act, that Black men are up to 5 times more likely to be diagnosed with schizophrenia, and that young Black people, particularly when I think of Hamlets, are far more likely to enter services through crisis pathways, not early support. And this really tells us something. This issue isn't about vulnerability. This issue is access, trust, systems that do not respond early enough. And then the group that we worked with, who are predominantly young Black men, painted a very clear picture, which in my mind is quite urgent. Up until early childhood, outcomes are similar. But as young people grow, the impact of racism, exclusion, and policing begins to shape identity, behavior, and well-being. And the research specifically looked at experiences of racism in school shaping self-worth, lots of challenges around self-esteem from a very young age. As early as 6 years old, the youngest person could remember feeling something uncomfortable. Over policing and criminalization creating fear, almost 99% of the young people felt that they were experiencing fear and violence on a daily basis, and services failing to recognize distress in culturally relevant ways. And this is intersectional. It isn't just about race. It is about gender, it's class, it's geography, it's faith, and migration. These experiences overlap and compound. Frantz Fanon reminds us that systems of oppression do not just control people, they shape how people see themselves. And when young men, particularly young Black men, are consistently seen as a threat, rather than as people in need of care, that has consequences. So one of the strongest findings in the research particularly looked at systems that often reproduce trauma rather than resolve it. Young people in the research, across the many sessions we held, particularly with Doreen, spoke about the cycles of mistrust, delayed support, crisis intervention, and coercive responses. But alongside that, something else emerged, that community works, and that grassroots spaces, particularly the 9 buildings that we now co-lead with community, cultural networks, faith spaces, I think of mosques, churches, and other faith spaces, are often the first place people feel safe, seen, and understood. And at Coffee Afrik, we build their spaces which are really fundamentally rooted in healing, where young people lead those spaces, and where spaces are rooted in trust, not surveillance. And where Paulo Freire spoke about the importance through the pedagogy of the oppressed, the importance of people becoming active agents in their own health liberation. This is what this work is about. And so, before I ask my amazing colleague, Khaleel, the youth lead, some pointed questions, if we take this seriously, then some small changes, as David spoke about, are absolutely urgent in this research, which are really, really possible. It will take a lot of us to do this, but anti-racist trauma-informed care across all the system is absolutely crucial. And of course, although funding is really difficult at the moment across the sector and services, long-term funding for community-led organizations are crucial. ELFT specifically, I'd like to shout out for the amazing work it does with community organizations across Northeast London, and of course, CNW as well. Real co-production and not tokenism. And it's really important to build that long-term co-production with communities. And the research kept and highlighted that throughout. I think one of the things that I'm still talking about after so many years is accountability and transparency, particularly in data and outcomes. And a shift from control to care. And how do we care for each other, particularly in this moment where it feels like we have systemic collapse? What Walter Rodney reminded us, who is an amazing practitioner, the question is who controls the system and for whose benefit? So this is not just about improving services. To me, it's about shifting power. I'd like, just before I end, to ask Khaleel, my colleague who works with an enormous amount of young people in East London, some questions. Khaleel, if I could bring you in, please. From your experience, how are young people describing their relationship with systems right now?
Thank you, Abdi, for bringing me in. When working with young people, they talk a lot about distrust and a disconnect in relation to services and their care. I think a lot of that disconnect comes from lack of relational trust and connection. They talk about a lot of trauma when it comes to a lack of cultural sensitivity. Young people have lived experiences rooted in their upbringings and their communities, but you have people coming in and practitioners coming in, telling them a different way, a different solution that they're not accustomed to. So what we're looking for is solutions and systems that are built around the community, for them, and led by them as well.
Thank you very much, Khaleel. And I'm just mindful of time, so I'll ask one other question, particularly because we're dreamers. We spend a lot of time dreaming about systems that don't exist, because we have to. And so my question would be, if we had a limitless budget collectively, not just within the third sector, what would early support look like if it was designed by young people themselves?
One model that I look at and I am studying right now is the triest model of care. And this is showing how communities can now take over what care looks like for young people. And I think it starts at community hubs, and it will be an overlapping system of care from mental, physical, social, emotional, and supporting that development and nurturing of young people as a collective system. And this will be led by and for the community, young people at the heart of it, communities at the heart of it. And this would give people the agency to now control what care looks like for them. And when it's controlled by the community, it has more engagement, more trust, and more positive outcomes overall.
Thank you very much, Khaleel. I really appreciate your work. Thank you. And then I really just wanted to close with a practitioner that we speak about a lot in our work, Dr. Beya Akomolafe. And he says, what if the way we respond to crisis is not to fix it, but to become otherwise together? So that is an invitation to everybody in this room, not to fix broken individuals, but to transform the conditions that produce harm. Because our communities are not broken. They are holding knowledge, resilience, and solutions. We just need to listen. Thank you.
Thank you so much, Abdi and Khaleel. I'm used to your power, but I mean, that was a really powerful presentation from you both. I'm now handing over the chairing role to my colleague, Professor J.S. Bamrah. And if people had their hands up before, please still put your hands up. Over to you, J.S.
Thank you, Marie. Thank you. Well, we've had really powerful presentations from our three key speakers, David, Abdi and Khaleel, and there's so much sense in that, and we've had huge audience. Thank you very much all for making time. I suppose we've had a lot of questions as well. We were sent some questions that are questions of clarification from the panel as well. So let me ask one question from the chat first of all, and tell me whoever's appropriate to answer this, please do. There was one question for Marie, which was about commissioning, Marie, that we picked on in the pre-interview. Would you like to answer that before you go?
Yes, so sorry everyone, I have to leave at 11:45. But yes, so the question was about the role of strategic commissioning. So integrated care boards are moving to be strategic commissioners. And that is still in its infancy, but there is a national guidance coming out about strategic commissioning. And as part of the Race and Health Observatory, we're seeking and actively seeking to inform what that looks like, you know, what that guidance and what that training and what that development looks like. But I'm also, as part of my other life, chair at North East London Integrated Care Board. And I've recently appointed a new chief executive, Dr. Nana Suji. And one of the things we're having a conversation with only tomorrow, actually, is about what does anti-racist strategic commissioning look like. And we're also starting a conversation with the Race and Health Observatory, who at our last board meeting had a conversation about, well, what does anti-racist strategic commission look like, but also what does anti-racist neighbourhood health look like? So although it's in its infancy, and actually we need to do this work with our community, which of course will include Coffee Afrik, because they're part of both our ICB and also Race and Health Observatory. And there's been some incredible work already in Tower Hamlets, actually, and how do we build on that? So we haven't got it sorted yet, but we actually want to sort what that looks like. Thank you.
Thank you, Marie. That was really helpful, very helpful. Let me pick on some quick questions, and then I'll come to the people who've raised their hands. It might be best to put all your questions in the chat because we have so many questions. David, this might be for you. This research or surveys is largely about London. Abdi, it might be for you as well. So how do you extrapolate your findings to the rest of the UK? And is this English-centric or England-centric only?
I think that's a good question. I think we're very often left to feel quite defensive about qualitative methodologies, and I think we were operating quite on purpose. We were operating with our partners, Coffee, Afrik, and the opportunities that they could bring us, and working with partners in West London, because we wanted to be able to have meaningful conversations and also to be able to engage in a way that left a positive legacy and wasn't extractive. So it meant that we were quite purposefully small scale. Whether that, I think the issue about whether it's applicable to other areas outside of London, or indeed outside of England, I would say obviously more research is always a good idea, but we were very careful to fashion the questions and to fashion the conclusions and recommendations so that they could work with what is already in existence, these national initiatives like PCREF, the Parent and Carers Race Equality Framework, national initiatives like the CQC standards, national initiatives like training standards, to be able to say that this is what we've learned in terms of the principles of what we think the approach should be, rather than working in the minutiae of the data and somehow assuming that what people's individual experiences were the same and replicable, but also what we thought could be generalized effectively in the context of a lot of research, a lot of commentary, a lot of activism, policy related commentary, academic commentary that actually does show a consistently depressing picture, that actually these issues are the same. Obviously, the local nature of things can vary very much on who's living there and the politics locally, but we are confident, and we're confident in our conclusions that from the work that we did, in addition to the literature review, that actually this does have an applicability that's much broader than just the areas in which we undertook the qualitative work.
That's really helpful. Abdi, did you want to give us your pearls of wisdom?
I think just very briefly, Chair, we do a lot of research around the idea of traumatized landscapes, that people are also sick because of the environments that they live in. I think the conditions that we live in are very similar to conditions in Moss Side. They will be the same conditions that exist in Butte Town. They will be the same conditions that exist in Toxteth and Liverpool. And so these conditions are in the built environment too, in the way that cities are designed, in the air pollution, and then other intersecting issues like housing and other education systems, for example. So I think this research absolutely applies to all cities. As far as Glasgow, I would say, as far as Scotland, and it isn't unique to London. It's unique to all marginalised folk, all communities that are particularly experiencing poverty. So I think for our work, and this research clearly showed that poverty is also one of the most key drivers of why the inequity exists and why people are getting sicker. And as a result, the environments they live in are also sick as well.
Thank you. There's a question from Carol Phillips. I'm going to paraphrase this, Carol, if you don't mind, which is about accountability of organizations on their journey of trauma-informed practice. So I don't know who's going to answer this. I don't know. Marie, would that be something you could help with? How do we hold organizations accountable? Seeing as you're the head of one of our premier organizations.
Right, yes, very quickly, because I'm going to have to drop off. I think there's a range of ways in which you hold organisations accountable, and I think the research that's been carried out by the Centre and RHO points to some of those. So who are the regulators and how do you work with the regulators is really important. And I know at the RHO we've been doing work, for example, with the Care Quality Commission, and who've adopted the 7 principles of anti-racism. We've also been working previously with the Department of Health and other partners around the training of those who deliver care, which is really important. But the most recent thing we've been doing is working with the Department of Health and Social Care, who are developing a sort of new staff standard. And within that, I know that the sort of department are looking at about anti-racist practice and challenges around gender as well. So how do you embed this in a way in which you place expectations on senior leaders, I think is really important too.
Thank you very much. Okay, I'm going to press on with some of our, get as many as I can. There's an important question here about intersectionality. So the question is, how do we provide intersectional care for those who are vulnerable, minoritized communities? They could be Black, they could be gay, LGBTQ plus, I plus, migrants. That's a very topical thing at the moment, asylum seekers. I don't know, Khaleel, you might have come across a lot of young people currently distressed. Would you be able to tell us how do we provide good care to them? Khaleel, you're muted. Hannah, can you help? Meantime, can I ask Abdi, can you unmute while Khaleel is trying to unmute?
I'll step in, Khaleel. I know what you do, sir, and inshallah I'll be able to do you justice. I think the first thing is, from what we witness across all the services, across the 33 projects we currently run, across all the women's support services, the drug support, the mental health support, it's very important, I believe, to treat people with dignity first. I think it's important to receive someone as a whole human. And for us, I want to really cite that intersectionality is a Black feminist idea. We recognize that you're dealing with a whole human who has multiple needs. And I think kindness is a basic pathway that Khaleel will apply in his service. There is clear conditions around support for that person, which is rooted in dignity and respect, as I said. And then when we're supporting a young person, particularly who's in crisis, Khaleel will often go through their whole family situation. He will also understand what's happening at school. He will also understand what's happening day to day for them in terms of police and other challenges structurally. And so really assessing someone as a whole person rather than just someone who's sick, I think is vital. And what I witness in the way that Khaleel supports young people, and also, of course, at our women's hubs too, is that people are really encouraged to have self-determination in their healthcare. And I would like to just touch on back to the Black feminist idea, but around accountability especially. If we get it wrong, we always start with an apology or restorative justice. We always start with healing first, and that sometimes happens even within our services. So providing care for someone as a whole human, making sure there's a very clear accountability frameworks in place, particularly for their care. Looking at this through a Black feminist idea is really important for us at Coffee Afrik. And then making sure that we deal with them through a whole process, a whole journey of not just their health, but as I said to you, all the other aspects of their lives. And finally, a good example of us doing that really well is after 7 years, our contract within Islamic Foundation Trust, we have community connectors who are part of a blended team. They've been providing support to thousands of patients over those years now. And what happens often, a person will come in and is provided with diet support, housing support, welfare support, employment support, and that support is long-term. It isn't just a tick box. And of course, that's a luxury, especially in our time. But I think it's really important to end with making sure that that service is culturally sensitive too. That the service you provide for that person is absolutely as much as possible bespoke for them, and that you see that that person is human.
Abdi, I love your clarity. I love your enthusiasm, honestly. We need for you to come up to Manchester to Moss Side, you know. Okay, I've got here a question. I haven't got a name fed through from Hannah. And this is about somebody who works in the secondary health trauma service. Very rare to get referrals from non-white people. And we're clearly missing huge amounts of community. And I wondered what would help us for them not to be excluded. And I'm thinking about the young Black people more likely to enter services through crisis rather than through preventative services. We have lost Khaleel, which is unfortunate. I think he was having some problems with his laptop, I suspect. So David, Abdi, whoever wants to answer this question. I see my co-chair at the RHO has joined as well. Steve might want to come in. Shall I bring in Steve, first of all, if you don't mind both? Because Steve has a lot of user experience as well as having an overall experience. Steve, welcome.
Hi, and apologies for being late. I'm actually just about to present to a group of mental health legislation managers and associates down in the southwest. So really on kind of trend with what we're talking about here, and I think what's just kind of to a bit of what I heard Abdi say earlier, we've got diverse communities all over the country. It's not just in the kind of what we think of as the urban centres. It doesn't matter if you're in Norfolk or, Glasgow, wherever you are, you have these needs that are need to be approached differently depending on the the constellation you've got there. I'm actually not going to really comment. I just wanted to say to David and Khaleel and to Andy and Abdi, just thank you for persevering. I think that this piece of work, we commissioned it quite a few years ago, and I'm so pleased that we have this report, that we have this launch, and that we have 270 people coming to celebrate. Abdi is absolutely brilliant. If you haven't had a chance to kind of check him out on LinkedIn, please follow him. Please follow Coffee
Right,
Freak.
Steve, I'm going to stop you there.
That was what all I wanted to say.
But the crucial, because we are limited by time, I'm really sorry. We're very limited by time. So I do want to ask that question from you folks, which is exactly that, is prevention. And we're clearly lacking in that in the NHS altogether, or the health services altogether. But how do we prevent a crisis from happening? I mean, Andy might be the person to answer this because he's got an overview of things and he's got a huge amount of experience through mental health services across the country. Andy, would you be able to unmute yourself?
I can try. I can see that Abdi, you kind of suggested you might want to come in on this, but I'm very happy to follow.
No, please go ahead, Andy. I'll chip in after you finish.
I mean, I think one of the things that's been said really clearly and importantly during this, and you've said it, is that communities are there, and community organisations exist in every part of the country, particularly those with more diverse populations. And if a service is not reaching a particular group of people, if a service is not representative of the population it serves, there's clearly a really important job to connect with those community organisations, really understand what is creating the distrust, and how those services could change. Simply kind of doing the same thing and hoping people will trust you more is no longer kind of a way for services to work. We actually need to look at what's being offered, what way it's being offered, who's delivering the support, what the relationships are with community organisations, rather than thinking we just need to shout louder and tell people more about what we got. So I think there is something about how we fundamentally rethink that, and it really starts actually with public health. It starts with knowing the population, knowing which groups of people are not receiving the right support, and where those gaps are, and then taking a really proactive approach. None of that's easy, but it's incredibly important because the NHS was set up to be free at the point of use to all and an equitable service. We've had an Equality Act since 2010. This really does need to be a focus for the next few years.
Thank you, Andy. Abdi, did you want to add to what Andy said?
Yeah, just very briefly, I think the question is so targeted because it really is about unmet needs. But I also think there are so many really quite traumatic test cases recently, and particularly at inquest levels, that show that the early support was lacking for so many people that ended up in really, really difficult, tragic circumstances. And I think it's really important for us to acknowledge that a lot of the investment isn't going to those key communities from an early support perspective. And then when I also think of people that then leave prison because of recidivism that go back, that kind of wraparound support also just doesn't exist at the moment too. So that person is often then undiagnosed or back in community. And then finally, I want to just give briefly a live example of of what we witnessed in Tower Hamlets, we noticed predominantly that Black communities were not going to pain clinics. We actually didn't even know these bespoke pain clinics existed in Tower Hamlets at specific GPs. And in certainly our community, particularly I think of aunties across Africa and the Caribbean, pain is a common daily lived experience. Pain in the body, in the spine, in other aspects of their lives. And so we've created today, for the first day, a pain clinic, which is happening at 12 until 3 in one of our own buildings. And I think there has to be a reimagination of where you hold these sessions. So if young people or young Black men, to the person who asked the question, the colleague, are not visiting that space, the question is why. You have to really sit within the uncomfortability of those questions. Is it an issue of who's holding that service? Is it the location of that building? Is it culturally sensitive? Is it dignified? Does it treat them as human? Are you offering other support, like a cup of tea like we do, hot food like we do at all of our buildings? And I think you have to radically reimagine that kind of care. And then finally, I think it's really important to anchor the service in local people, all of the buildings across the 9 buildings now, 33 colleagues run those spaces. And every single one of those people are survivors or have living experience. And they are from literally the boroughs that they serve in. So I think it's really important that we try our best from a HR recruitment perspective too, to really recruit local anchors who can then really help you with engagement. And I think that's fundamental, particularly for unmet needs.
Thank you very much. That question was from Amelia. Thank you, Hannah. And a related question, I suppose, is about culture. This is from Julie Best, which is, she works in mental health services as a social worker. How is it possible to change the culture? Not about the individual. How do we change the culture of a place? I can see Abdi getting a bit, I don't know, excited or desperate or quite concerned about that. How do we? I mean, it's like a huge. Well, I wasn't going to use the word Titanic, but maybe that's not appropriate. We know what happened to the Titanic, but it is a big issue, isn't it? How do we change the culture of a place? Maybe a short answer from somebody, because we could be here for a long time about culture. Would anybody venture in? Yeah, David, go on.
I mean, my understanding of it is that there's no one thing is going to shift a culture. I think people have taken quite a transactional approach. They think it's all about policies and about the way things are described and the way things are structured. Those things clearly are absolutely essential, but at the same time, there's got to be a hearts and minds thing. There's got to be a thing where there's got to be a confidence in which people can challenge poor practice. There's got to be something deeply relational to understand how you shift a culture, because even though it might be described as something that can be fixed by processes and protocols, that's only, alas, a very small part of it. And we have to make sure that people keep those both sides, the relational aspect as well as the transactional aspects, I would say. But also put people in positions of authority that actually are most affected and can make and understand what the change needs to be. I think that clearly is the message that came out of the research that we did.
Yeah, it's about, unless you look like I look or the community looks like, it's not going to be effective. Thank you, David. I'm going to pass on to a very important question, which is actually recommendation 8 in the report, which is about schools. So how do we embed this sort of learning right from school? Because that's where it's needed, isn't it? So how do we go about that? Abdi, are you good at answering? I'm afraid we've absolutely lost Khaleel. I'm so sorry about that. So, yeah, go on, Abdi. How would Khaleel answer this question? Let me ask you, as your youth lead.
Khaleel is might actually be back. Yes,
Khaleel is back. Khaleel, do you want to answer this question? Can we hear you? Can you unmute?
Yes, I'm here. Yes, sorry.
Welcome back.
Apologies for the technical difficulties. Could you just repeat that question for me, Jess?
Well, the question was, it's in relation to the 8th recommendation about Department of Education. And the question is, how do we get schools to embed in this sort of training? Because, trauma-related questions, trauma-related awareness, right from the start for young Black people and other traumatized communities. What do you think schools should be doing?
I think there is a disconnect right now between community services and statutory partners like schools. what would be beneficial would be having lived experience practitioners and living experience practitioners, especially as young people are from those local communities, but we very rarely see practitioners from those local communities. And they have such a great impact because they have that cultural sensitivity and understanding of what are the direct needs of the young people in those communities. So when we have those people of representation from the local community in statutory partners like schools, we will see a lot more accessibility when it comes to that model of care, when it comes to young people now having someone that they can have relational trust with and a support network that they can get communication from and they can train with. So especially having training provided and workshops provided by those youth practitioners from local communities will help bridge that gap a lot better.
Thank you. That was really helpful, Khaleel. Thank you very much. There's a question here, moving on swiftly. It's a question that we can't answer, any of us, but it's a question. Are you aware of recent research in Wales on lived realities of racial trauma? And whoever's got the answer to that, can you pass it to Hannah? And we'll certainly try and include that in the report to this very informative seminar. Okay, now I'm going to now I know that we've got one hand up from somebody, and I think that somebody might be Murchan Madun. Okay, Madun Fulchan, hang on to that. I am going to ask you to ask that question, but I've got so many questions here that I just need to try and grab as many as I can and a variety of them. So hang on to that. Now, so what about incorporating one of the pre-questions we had was, could you also speak to how we incorporate anti-racist approaches in mental health promotion? So mental health and this sort of trauma, bullying, harassment, racism is a big issue amongst our patients and service users, and also amongst the staff. So what do we do about that? I don't know if Steve would be the best person to answer this. Steve, are you able to answer that question?
I'll give it a go. I mean, I think the next stage for me is embracing uncomfortableness first and foremost, and the fact that it is real. And that for all of us, we will have a sense of guilt about what we did or didn't do. Or, you know, especially if we're people from affected communities, that we've internalized something. And I think, you know, we can look at all the processes, and the process is really important. But I think that acknowledgement of something is wrong, it's going to be uncomfortable, and we will be in a period where we only have part of the puzzle. So, for example, we've got things like PCRAF, and now we've got this report. So we're starting to kind of find our way forward, but we still need to search. And the NHS and social care doesn't do very well with uncertainty. And then to Khaleel's point, you know, and he's about the work in schools. When you bring the community in, they are the people that go, you're in the right direction. No, don't go there. That's the wrong direction. So it's this collective, but we have to admit that we don't always know the answer, and then trust and work with each other. That's the best answer I can give in 60 seconds.
Okay, lovely. Okay, Madan Fulchand, this is your time, but can you be brief? I know I've seen your question, but I want you to say it yourself, if you can be unmuted.
Okay, can you hear me?
Yep.
Yeah, okay. I mean, it's not like a question. It's like more of information sharing. I live in the West Midlands. And
You'll have to be very brief, Madan.
Yes.
We're running out of time.
The question is, there is a research being undertaken by National Institute of Race and Genes, and it's all about focusing on Pakistani and Bangladeshi people, and it's focusing on genetics, which basically ignores all the social determinants of health. I just want to know whether people know about it, and what we need to do is to actually discuss both versions, because this research is only focusing on genes, not on the social determinants. And I would like help from people in the panel.
So let me refer you to a piece of defining evidence on this, which is a book that I have authored and was launched in House of Commons on Monday, which is called Anti-Racist Medicine. So do please all, it's a plug for that, and it tells you about how genes and how slavery and the impact of colonialism and all of that history is captured in a very academic fashion in Anti-Racist Medicine. It's published by Elsevier, a large medical publisher, so do look online. Abdi, you were though nodding your head, so you're chiming with what was said then by Madun. Do you want to answer that question? How do we bring in social determinants and not necessarily just rest on genetic research?
Exactly. That's the point I'm raising. I mean, they're focusing too much on
That's
genetics.
okay, Madun. We only have 2 minutes. Sorry to cut you off.
Okay.
I just wanted to support you, Madam, about your point. I think there is an avoidance to also look at the reasons for why someone is unwell, and not just to blame the person's genetics. I think what you're referring potentially to. And I also think that there is a real concern that we don't look at, as I said earlier, the built environment, systems and other injustice, particularly structural racism. There's a constant reason in the system to ignore that this is one of the biggest drivers for why our communities are at most risk or most struggling. And I think the conversation of genetic research is quite challenging in our experiences too, and we try to avoid going through that particular road. But I will encourage you to keep testing whoever that is that's leading the research where you are, and keep creating good trouble locally.
I am.
Thank you very much, Abdi. Okay, folks, we have come to the end of our I know time was a bit tight. We could have gone on for much longer, but this is what time allowed, and maybe we need to do a follow-up at some point about this. But I have very many thanks to give just now, and I want to thank my co-chair, Marie Gabriel, for being here. She, as you know, is the chair of the NHS RHO. I want to thank Andy Bell, who's always been very supportive, the CEO of Centre of Mental Health, and of course the authors of the report, without whom this piece of work would never have been done, who've been very patient with us, with Sam, Steve and I, Abdi, Hassan, Doreen, Joseph, Adi Observatory, David, and of course Andy is also a co-author on this report. I want to thank you all for making time. We've had nearly 300 people on this very busy seminar. You've been absolutely wonderful. Khaleel, I might have missed your name. I'm so sorry, but thank you very much for that. Now, this piece of work would not have been possible without Steve, Sam, and the Mental Health Advisory Group at the RHO agreeing to fund this. And this has been in the making for a while. So my thanks go also to all my colleagues. The most important thing in this, and it is in the report, it is about listening. Would you believe it? The essence of this was to listen, give people the safe space, even if you don't have the answers. The most important thing I took from this, apart from the 8 recommendations, is listen. Even if you don't have the answers, listen patiently. Do not be judgmental. Please give them safe space. It could be your child, it could be your brother, sister, it could be a colleague, could be a patient, service user. Give them a time in their distress to be able to listen to them. And so thank you very much, folks. I want to thank Hannah, who's been absolutely amazing in organizing this for the Centre of Mental Health and on behalf of RHO, and of course our Secretariat, Sam Roger, without whom we would not have been able to do anything in our Mental Health Advisory Group at the RHO. So thank you all. Thank you all to all the participants on behalf of the NHS RHO as well as the Centre of Mental Health, and Coffee Afrik for being here. Thank you so much. Have a good day and have a good weekend.
Thank you
Bye-bye.
very much. Bye.